Thank you. And thank you, Donna, for that lovely introduction. That's really, really kind of you. And thank you again for chairing our meeting this afternoon. I'd also like to thank BAUN, actually. It's been just the most amazing day. It's so diverse. I've learned so much, and I'm sure we all feel the same way. And I'd also just like to thank BXTA for inviting me to lead this symposium. It really is a privilege to be here with you all. So as Donna mentioned, I'm a prostate and brachytherapy nurse specialist, and I'm based at the Royal Surrey Cancer Centre in Guildford. Prostate cancer makes up quite a large amount of our work. We are a tertiary referral centre for a large cancer alliance, taking up quite a lot of the southeast of England. And we're very lucky. We've got this gorgeous urology building. You don't often get to see the word urology up in lights, so we're very aware of how lucky we are to have such a nice centre. We treat about 500 men a year with robotic-assisted prostatectomies. We treat about another 500 men a year with external beam radiotherapy, again using the latest technology. And back in 1999, Stephen Langley, who's a urologist, and Robert Lang, who's an oncologist, set up the brachytherapy service in Guildford. And since then, we've treated just over 6,000 patients, and we perform about 300 implants a year now. So it's a very large part of our cancer treatments. Now, I'd just like to ask very quickly a little bit more about you. Can I just get everyone to put their hands up if they're ward nurses? Any ward nurses? A couple there. Nurse specialists? Oh, yeah, loads of us. And any other allied health professionals? Fantastic. So I'm sure that we know that we're going to come across patients that have been affected by or need treating for prostate cancer. So this is just an overview about what we're going to discuss this afternoon. And I think it is a really important conversation to have because as nurses, I think we're in a unique position to offer our patients an overview of the knowledge that we have to empower them to make a decision about the treatment options that they have out there. I believe that the nurse-led clinic is the best model for the first diagnosis information to be exchanged. And I think that it enables us to share our knowledge, to give them the confidence and control to make a decision about their treatment that they are comfortable with. We all too often see that in the first consultation, perhaps led by a surgeon, the surgeon will give the diagnosis potentially, and then say, and I can cut it out, you've got cancer, I'll cut it out. And the patient, of course, as we all would, will just say, yep, thanks, when can you do it? But we know with even the high-grade prostate cancers that patients do have time to process and to think about what treatment options they would prefer and to look at the quality of life issues. So we're going to focus today on brachytherapy. And brachytherapy itself comes as low dose rate, which is known as LDR, or high dose rate, known as HDR, not unsurprisingly. And today we're going to really focus on LDR brachytherapy. So here we've got an overview again. The LDR brachytherapy is the implantation of permanent titanium seeds that contain a source of radiation, iodine-125, that is delivered over the course of about 9 months. And as you can see, the CT scan here shows the permanent seeds implanted into the prostate. With the HDR, we use a temporary source of radiation, iridium-192. Again, it is transperineally, but the bead of radiation travels through catheters up into the prostate, and then both the needles and the source of radiation are removed. So these are the main differences you can see here. So LDR brachytherapy delivers a high dose of radiation to the prostate. It's quite ironic, really, that we refer to it as LDR and HDR, because often the LDR will give a higher dose of radiation to the prostate. It's actually referring to the isotope that's used, which is high and low. Sorry, that didn't make sense. This is a permanent seed implant, and it can be used as a standalone therapy or in conjunction with external beam radiotherapy. And for that reason, we can use it for low, intermediate, and high-risk prostate cancer patients. We have long follow-up. As I mentioned, the service in Guildford alone was established in 1999. And whereas HDR, they generally treat the prostate with a lower dose. It's a temporary implant. It's normally in combination with external beam radiotherapy and used for high-risk patients, particularly those with seminal vesicle involvement or what's called T3B disease. The Follow-up is a bit shorter, and there are multiple protocols and doses that are actually used across the country. So what I'd like to do now is just show you a short video. It's just about 5 minutes long. It's a little bit, what's the word I'm looking for? It's a bit stiff, I suppose, and I'll just try and commentate exactly what it's showing. It really is looking at the assessment process in clinic, see whether someone's suitable for brachytherapy, the ordering process, and then the actual implantation itself. So let's have a go. So we're starting off in the clinic setting. So this is just Stephen carrying out a transrectal ultrasound scan in the transverse view here, and he's going to be measuring the height and the width of the prostate to calculate the prostate volume. Again, now we've switched to the sagittal view, and he's going to measure the length of the prostate and then the anterior and posterior lengths as well. And those images will be printed off and then sent to our physics team, who will carry out the calculations. Here's Mel, our physicist, and she is using the BXTA portal to order the seeds for this individual patient. And the measurements that we've taken are then used to calculate the volume, and that will then give them an order for the seeds, which are then sent out. We always order a few more seeds. The nomogram is designed to send more seeds, just in case there are any variations on the actual day. So now we're at the time for the brachytherapy implant. So you'll see here, this is under a general anaesthetic. This patient's in the lithotomy position with Stephen and Robert. It's a two-person job. You have the ultrasound scan here, and you can see the probes is set up transrectally. And there's also Robert's working on a computer, which is working out the dose of radiation that the prostate is going to receive and where to place the seeds. At this stage, they're using the ultrasound scan to draw around the edge of the prostate, and they're doing that at 5 millimeter intervals so that they can create a 3D model of the prostate. So here we're about mid-gland. And then we go right through to the apex here. So whilst that's doing, Robert is also then working out the position and the arrangement of the peripheral seeds. These peripheral seeds marked with the double yellow circles, they are the stranded seeds. So they're put in first. They're the ones that are stuck together with a polymer that it means that they can't move, which is good from a migration point of view. And it also enables them to give a really accurate dose. And they're going to do that through the whole gland, so modelling it as a 3D image. And now what Stephen's doing is marking on the ultrasound where he's going to put those needles so that he can target when he puts the needles into position. And that's his view. So here are the stranded seeds. The seeds are actually inside these needles, and they're being placed as you would imagine exactly where they should be. You can just see quite nicely the flash of the needle in line with where the implant is heading. At the same time, Robert is now marking the urethra, and he's doing that at 5 minute intervals so that we can make sure that that doesn't get exposed to too much radiation. And then we're also marking the rectum here as well for the same purpose. So whilst that's going on, Stephen has finished putting all the seeds in, and Robert's now working on the centre part of the prostate where they will place loose seeds so they can work around the urethra. It's very much a live process, so they are planning as they're implanting and able to respond to any issues that they might have or any concerns they have about dosimetry. And here Stephen is just leaving the seeds behind and then removing the needle. This is just the sagittal view. You can see the flash of the needle at the top there. And this whole process is usually done very quickly. It probably takes about 20 minutes to do this. As if by magic the clock appears. So this is how the software has now generated a 3D model of the prostate with the peripheral seeds in place. The urethra is in green, and this is the radiation cloud that the seeds have now provided. And so now we're just going to complete the implant by putting these central seeds into position. Again, we're recalculating at this stage to make sure that it's it's based on where the peripheral seeds are now, rather than any original plan, to make sure that it's as accurate as it can be. And then we're going to insert the loose seed centrally. Stephen here is just marking where he wants to put the central needles based on the plan generated by the software. And these needles don't contain any seeds. They're just empty barrel needles. And you can see the little white flashes where the needle tip is in the correct position. And I quite like this next positioning because he's slightly to the left of where they were aiming for. So Robert will then correct the plan by moving the software image over to accommodate that, to make sure that it's still going to provide a good implant. And this is called the MIC applicator, and that chamber at the top there is containing the individual seeds. And that's it. That process takes about 40 minutes to an hour in total. It's a day case procedure, so the patient will wake up from the theatre, have a CT scan, which is done to confirm they have enough seeds to give them a good dose of radiation, and they will then have their catheter removed, and once they've passed urine, they can go home. It's a really easy, straightforward process to use. So let's look a bit more about who might be suitable for an LDR brachytherapy implant. So really it falls into both urological and cancer issues. So urologically, the prostate size needs to be below 75 grams, and that is because you can see here, this white line is marking the pubic arch, and you can see this nice 40-gram prostate fits really nicely underneath that with no shielding. But when we have a 70-gram prostate, unfortunately, some of that is blocked by the bone, so you wouldn't be able to do a good implant that was uniform and treat the entire gland. Patients, obviously, because they're in that lithotomy position, need to be able to flex their hips to 90 degrees. And unusually for the urological world, size doesn't matter when it comes to an LDR brachytherapy implant. And that's because, as you can see, the perineum effectively doesn't really change shape regardless of how large the man is. I'm just going to remove him. And we know that we're living in a society where we are dealing with obese patients. It's becoming more and more common. And perhaps prostatectomy wouldn't be a great idea for many reasons for those larger men, not least the anaesthetic. Whereas with a brachytherapy implant, you can have it done under a spinal anaesthetic or a general anaesthetic, as well as the perineum not changing size. The other thing we need to consider, again looking at the shape of the prostate, is whether they've had a previous TURP. So you can see here this green area is marking a TUR cavity, a traditional TUR cavity. It would be quite difficult to put an implant, a uniform implant into this prostate. We can, however, use a form of almost like a bladder neck resection pre-brachytherapy if it's a planned thing, so that we can optimize their urinary symptoms. And I'll explain why that's so important shortly. We generally need their IPSS score to be below 15, and that's the International Prostate Symptom Score. It's a way of assessing their lower urinary tract symptoms. And if they have a high score, it generally means that they're going to have some issues potentially post-treatment. Another positive thing, another advantage, if you like, of brachytherapy is that we can use it where perhaps external beam radiotherapy might not be the best option, such as those patients with diverticulosis. It can also be used in patients with irritable bowel syndrome or previous bowel surgery, such as an anterior resection. It can also be used for patients that have had a bilateral total hip replacement, and we know that makes planning very difficult from an external beam point of view. So that's urological. Let's have a little look at things from a cancer point of view now. So because, as I mentioned, brachytherapy can be used for low, intermediate, and high-risk prostate cancers, it can be given in different ways. So for our low, most favourable prostate cancer patients, we can use a brachytherapy as a standalone treatment, and that's called brachytherapy as a monotherapy. That would usually be patients with a Gleason grade 3+4 or below, and with less than 50% of the cause involved. For the higher risk cancer patients, we can use brachytherapy in conjunction with hormone therapy. We usually use bicalutamide neoadjuvantly, and more recently we've started to use relugolics with increasing frequency. And that's really for those patients with the primary pattern 4, Gleason pattern 4, or with over 50% of their cause involved. For our highest risk prostate cancer patients, we can use brachytherapy as part of what's called a trimodal treatment plan. So hormone therapy, which is usually given for 2 years, and followed by external beam radiotherapy. That could be external beam radiotherapy to the prostate and all the nodes. And finally, we can follow up with a brachytherapy implant. Now, in this circumstance, that's called an LDR brachytherapy boost, because we're really using the brachytherapy part of the treatment to boost up the dose of radiation to the prostate. So hopefully you can see that it is a really versatile treatment for all manner of prostate cancer diagnosis. But does it work? So this is a study that is the largest study actually to date, looking at men under 60 with 15-year follow-up, which was published by our centre. So this is just the demographics. So you can see here that the median age was 57 years old. 53% of our patients in this study had low-risk prostate cancer. 37% had intermediate risk, and 10% had high-risk cancer. And we're looking, first of all, at overall survival. So this This is overall survival. And you can see here that at 10 years post-treatment, those men with low risk prostate cancer, 98% of them were still alive. And those with high risk, 93% were alive too. So we're not over-treating our men. We're not treating men that didn't really need treatment because they were going to die of something else. If we look at here, this is the prostate cancer-specific survival. Again, 99% of men with low-risk cancer are still alive 10 years later, and 95% of men with high-risk cancer are still alive 10 years later as well. So then we look at the PSA-free survival. So this here shows that at 10 years, 95% of low-risk men were PSA-free, and 87% of high risks were also PSA-free. So we know that it works. And because we have such long-standing and detailed follow-up, we were also able to publish this study where we worked with NHS Spine to find out all of the men that had LDR brachytherapy, to find out which of those were still alive and which had died. And if it mentioned prostate cancer on their death certificate, they were classed as a prostate cancer death. So this is really finding out, does this work in the long term? And so we're looking at actual survival rather than PSA-free survival. And we know that that's the question that most patients want. When you first give them their diagnosis, they want to know whether this is going to kill them. So we can see the overall survival here, and this is going up to 20 years. 70% of men, so basically 30% of men, overall survival, had died of something else by the time they got to 20 years post-treatment of LDR brachytherapy. And the chance of dying with prostate cancer over here was an 8% post-LDR brachytherapy. So we know that it works. So it might be good then to compare it to some of the other nice approved treatments that are available. So let's start with radiotherapy. So we know that we're looking here at the relative biological effectiveness, which is the concept of how effectively radiation causes biological damage. We know that the higher the dose of radiation that the prostate can receive, the higher the chance of cure. And so back in the day, conventional radiotherapy, the target dose was up to about 64 gray. And with the advent of IMRT, which enabled the teams to focus the prostate more closely, that was increased to about 80 gray. Now, with the advent of the release of the PACE-B trial results, we now see that we can increase that to about 90 gray, and that's called stereotactic or SABR radiotherapy. And that's up to 90 gray here now. But look at brachytherapy. LDR brachytherapy has already, and has been for the last 25 years, reaching over 100 gray. So that's optimizing their chance of cure. I think this slide quite nicely demonstrates why that is. So here we are looking on the left side. This is, too quick. there we go. So IMRT, you're getting aiming for a 78 gray and with a large, wide dose paint extending out across the surrounding tissues. But with LDR brachytherapy, you can reach 145 gray with not that wide collateral effect. And in fact, you can safely escalate that dose up to 217 gray, which is going to optimize our chance of curing further. So I don't know how your oncologists have been recently, but ours are very excited with the advent of the stereotactic radiotherapy or SABR treatment. So we now know that you can treat the prostate over 5 visits. And this is being seen as potentially the future. But I just would like to take a closer look at the reality of a 5-fraction treatment. So we're going to compare directly brachytherapy versus SABR. So this is the number of visits that the patients are going to have. So the SABR, we've got the clinical review, and they're assessed to make sure that they're suitable. They then have to come back probably a couple of weeks later to have their gold marker seeds inserted so that they can target the radiation at the prostate. And that's done under a local anaesthetic transperineally. At that stage, they can also have spacer gel insertion if they needed it. And then approximately a week later, they would return to the hospital to have their planning CT and MRI, or MRI. For that, they would need to have had a rectal enema previously and a comfortably full bladder. We all know it's not easy to get a comfortably full bladder. It's a bit of an oxymoron, really. And they will then have to come for their 5 visits of 5 sessions to have their radiotherapy treatment. And so that's given over the course of 2 weeks. So we're actually looking at least 8 or 9 hospital visits. Compared to LDR brachytherapy, we have 1 clinical review appointment. At that stage, the transrectal ultrasound scan is carried out. The seeds are then ordered based on that information. And so the next time they come back to the hospital, it's for their brachytherapy implant. And this is done under a day case, under a general or spinal anaesthetic. They do need bowel prep the day before, but it's 2 hospital visits in total. So it does kind of make me think that is this really for the patient's benefit or convenience, or is it more for the healthcare provider's convenience that's pushing stereotactic radiotherapy? Excuse me. So I also wanted to look, so what we've done so far is really only look at the brachytherapy as a monotherapy. So it'd be quite useful to look now at when we use it for the higher risk prostate cancers. And this is the ASCEND trial. It's a large randomized trial, which is pretty unusual in urology in itself. And it was comparing external beam radiotherapy versus external beam radiotherapy plus an LDR brachytherapy boost. And we clearly can see a survival benefit with the LDR boost. In fact, as it states, the men treated with external beam radiotherapy alone were twice as likely to experience PSA failure. So we know that it works for our patients. We know that it can be used for all types of cancer, and we know that it's a convenient way to receive treatment. How does it compare to surgery? So we all know how our surgeons all nurses know how enthusiastic surgeons are to operate. And for the right patients, prostatectomy can be exactly the best treatment, particularly those with obstructive urinary symptoms, or which would treat those symptoms as well as treating their prostate cancer. But we certainly know that surgeons generally believe that their treatment works better than the other treatment. But this study, there's no real decent randomized studies comparing LDR to prostatectomy, and this is only one of a few, and this is one with long-term data. And you can see quite clearly here, there's no difference. No difference at all in PSA-free survival. And these 2 studies came to the same conclusion as well. So we know as nurses that we can give evidence-based assurances to our patients that the only 3 NICE approved treatment options for early prostate cancer all have the same chance of cure. Our patients can't make a wrong choice. If one of the treatments worked better than the other, it would be our duty to encourage them to have that treatment. And I personally drill it into my patients that they can't go wrong. I think a big fear, it's quite a daunting time when you've been given this diagnosis and you are then expected to make a decision about something you probably feel quite ill-informed to do. we can reassure them that they can base it on something other than whether it's going to work, because all three of those treatment options are going to offer them the same chance of cure. So what can we guide our patients with to help them in making their decision? How about quality of life? So we're going to look here at the, on average, the average life expectancy now for a man in the UK is around 80 years old, provided that there are no red buses with their names on it. And we're diagnosing men at younger and younger ages. So it's a lot of life to be living, left with long-term symptoms post prostate cancer treatment. And we're the ones that are following these guys up, so we know what it's like and how debilitating it can be to live with those symptoms. So what can we expect post-LDR brachytherapy? So not unlike this poor chap's head, we know that the prostate swells, particularly in the first 3 months post-treatment, generally peaking around 6 weeks after the implant. This leads to obstructive symptoms such as dysuria, nocturia, urgency and frequency. But it can usually be well managed using an alpha blocker such as tamsulosin and going caffeine-free. I feel that I've flogged so much red bush tea to my patients. I wish I'd got shares in the company, and I could probably be living on a Caribbean island right now if I had done. Incontinence is very rare in brachytherapy, less than 1%. Sorry. So what are other aspects that are important for our patients post-treatment are erectile function. The expectations of our patients are that they have a satisfying sex life for as long as possible. And here we can see a study, again posted from data from our own patients in Guildford, that 83% of men were still potent 2 years after brachytherapy, after an LDR brachytherapy implant. Some of those will be using a Viagra-type medication, but we're very proactive in encouraging that use to promote their erectile function. Now, you'll probably remember this study from earlier. This is our patients under 60-year-old data. And it's the same study, but we're now looking at the quality of life. So you can see here, this is the IPSS score, the International Prostate Symptom Score. Again, as we would expect, we have a peak of symptoms at about the 3-month mark, and then they gradually improve. But look at this potency data. So this is a 5 years follow-up, and look, they're still potent after 5 years, which we know is something that men have the right to expect and to want. So there's not many studies out there that compare all three of the NICE approved treatment options. This is one of only a very few, and it is a large patient-responded study. It compares prostatectomy versus brachytherapy and external beam radiotherapy. And we're starting off with looking at the sexual dysfunction. You can see brachytherapy is the clear winner in terms of likelihood of maintaining potency. I find this quite an interesting chart in itself because I find it quite fascinating that they've separated non-nerve-sparing and nerve-sparing patients in the prostatectomy section, but the rates of potency are about the same. And we know that our surgeons are very keen on promoting non-nerve-sparing as a way of maintaining potency. This data suggests that perhaps that isn't the case. Incontinence, as you would expect, post-brachy is very rare. And we do have a degree of irritative symptoms, but we know that they settle down usually after 3 months. From a bowel point of view, again, there's an improvement on the bowel symptoms compared to traditional external beam radiotherapy. So to summarise the treatment options, we know that all three of these treatment options have the same chance of offering PSA-free survival at 10 years. Brachytherapy has a less than 1% incontinence rate and an up to 85% chance of maintaining their potency. It's a day case treatment, and usually patients can be back at work within 2 to 3 days should they wish. But you're thinking, well, it's all well and good for you, Claire. You work at a brachytherapy centre. How about if I want my patients to be able to have it? Brachytherapy, LDR brachytherapy, is widely available across the country. And you can see from this map, there's a centre throughout the entirety of the UK. And as we know, certainly in NHS England and NHS Scotland, you can be referred to anywhere within your own NHS group. And so we quite often have referrals up from Cornwall and Devon. The patients will travel up to have their assessments. They then come back a few weeks later to have their brachytherapy implant. And we do all of our follow-ups using over the telephone. So we're not expecting patients to schlep across the country on a regular basis. But we're also not expecting local services that perhaps haven't had as much experience with brachytherapy to manage any ongoing symptoms that they may have. We find that we usually get the local GPs to arrange for their PSA blood test so we can monitor the effectiveness. So in conclusion, I'm hoping that you can now see that brachytherapy is a very effective treatment for all types of prostate cancer and can be used in conjunction with hormone therapy or external beam radiotherapy. It is suitable for young patients, and it's a cost-effective treatment that offers an improved side effect profile. It's the only minimally invasive treatment with nice endorsement, and it should be discussed and offered to newly diagnosed prostate cancer patients. Thank you. I just wanted to point out that BXTA have got their stand at number 35, and they've got these really, I think they're quite cool, we need to get a life, but these cool cards that contain a dummy seed, and on the back is a QR code, so if you wanted to signpost your patients for more information about brachytherapy. We're just in the process of relaunching our own website for Guildford, which will be brachytherapy.uk. If you did have any questions or patients that you wanted to refer to us, you can just use my email address. I'd be delighted to speak to any of you. Thank you.
Thanks, Claire. That was a really insightful presentation about brachytherapy, and hopefully you all enjoyed it. There's been quite a few questions on the app. Just want to see if there's any show of hands first for any questions in the audience. Yes, please. And there's a few questions just while the mic comes to you. There were a few questions asking about erectile function. I think Claire's now covered that in her talk, and also about the fact that the urinary side effects were temporary. But yeah, do you want to go ahead?
Thank you, Claire. That was a very good talk. I work in Addenbrooke, so we do provide brachytherapy. So my question to you is, have you had any comparison between active surveillance and brachytherapy?
Sorry, any comeback, did you say?
No, comparing the active surveillance and brachytherapy outcome, like 5-10 years.
That would be, we haven't done it personally in Guildford. I think it would be an interesting thing to see how long, to see if we can kick that can further down the road with the active surveillance.
Yeah, because a lot of patients in your paper that you showed was early prostate cancer.
Yeah, absolutely.
And the Prostate study showing active surveillance is as good, isn't it? That would be good to do, probably.
Yeah, I think it's a very valid point, absolutely.
Yes. And do you, when you counsel patients, I do the counseling side of things, breaking bad news as well. So when you talk to patients about brachytherapy and SBRT, how do you finding that? Do you use those numbers of hospital visit and explain to patients?
I don't tend to quote lots of stats at patients at that time. I always think, in my mind, I always imagine that if you're given that news for a short time, you're going to be in a bit like a washing machine. Your head's just going to be sort of processing it. And I'm not sure throwing a load of stats at a patient is necessarily the right thing. Some men probably would respond quite well to that, but that's not really something I tend to do. And I make it very clear at that first consultation that I don't want them to be making any decisions. Actually, this is just an overview of all of the symptoms, all of the treatments, that are available to them. And at that point, I give them some written information as well. And then I book them for appointments with the surgical team, the brachytherapy team, and the oncologist. So they do get an opportunity, having had a bit of time to process it, to actually meet with those teams to get more information.
Thank you for that. So yeah, as I say, there are quite a few questions, but in the obviously want to honour our time constraints. Would you, so coming back to erectile function, because that's quite a few of the questions are asking about erectile dysfunction, particularly compared to radical prostatectomy and the newer techniques with radical prostatectomy. Would you recommend particularly that patients go on to regular tadalafil, so daily tadalafil for penile rehab, the same way that we would for RARPs, or is there any other sort of considerations that you discuss with patients?
Yeah, absolutely. I think that's a really interesting question. We know, certainly in Guildford, our prostatectomy patients are started on tadalafil, almost from day one, which I think is a really good thing to do. We've had conversations about doing the same for our brachytherapy patients. We do want them to abstain actually for the first 4 weeks post brachytherapy implant anyway, just really to give those seeds a chance to settle in. So I think I think in my experience, we've generally started them on sildenafil, but we could look at tadalafil. I'm not sure whether we'd start them on 5 milligrams daily or whether we would treat them with the 20 milligram tablet first of all and see whether they had much of a response. Because in my experience, if they don't respond to the 20 milligrams on a sort of once or twice weekly basis, they don't tend to get much of a benefit from the 5 milligrams. So I suspect that that will be the future, but I think we wouldn't start them straight away. I think we'd want to give 4 weeks off before we put them on. But I've absolutely, that would be a very good thing to consider.
Yeah, and I think also we tend to want to see how they are at 3 months, because often a lot of them have got their sexual function back at that stage anyway. So otherwise, just one, are there any other questions from the audience? Otherwise, we'll just do one last question here. What do you think, just because of the advent of stereotactic radiotherapy, what are the real advantages of brachytherapy over external beam or SABR?
Well, I think pretty much. I think from my point of view, I think there's a convenience for the patient is one thing, as I kind of alluded to there. But I also think we know that SABR is only really able to give the same sort of levels of treatment. The dose that you're receiving from stereotactic or SABR radiotherapy is the same really as you're getting from traditional external beam radiotherapy. But brachytherapy has already been able to give a higher dose. So, we know that's going to optimize their chance of cure. So you're effectively comparing, using a treatment compared to a treatment that doesn't give us a higher dose in the first place. I'm not sure if I'm quite articulating that clearly. I think that I think in the future, what we should do is look at comparing stereotactic radiotherapy to LDR brachytherapy. And that's literally something that we're in the process of developing at Guildford. There's going to be a... what's the word I'm looking for? My brain's shut. Yes, a study, but the randomised, that was the word, thank you. A randomised study comparing stereotactic radiotherapy patients to LDR brachytherapy, and both of those arms will have spacer gel inserted as part of that study.
Okay, thanks guys, and thank you for staying again. We do appreciate it.
Thank
Hopefully you'll feel a bit happier about talking about brachytherapy to our patients now.
I apologise, I was a bit clumsy with the IT. Thank you all very much.